Hi everyone, I am Deborah Hall and I am a neurologist and movement disorder specialist. I will be delivering a lot of your clinical neurology lectures, and you will likely meet me live and in person when we get to the brain and behavior block. I'll be in a lot of the small group teaching sessions. I want to show you my picture. You can see it here, just so you know what I look like. And on this first slide, you'll see I have a small picture on the bottom right, which is my key that a particular topic will show up on the STEP exam. This disease, Myasthenia gravis, is a favorite for testing on the STEP exam, so you will want to learn these concepts and circle back to this lecture, especially as you get closer to that. My background is that I'm a movement disorder neurologist, and so I see patients in the clinic who have tremors, Parkinson's, and other movement disorders, although I am board certified in general neurology like all of us on the faculty. So let's talk today about myasthenia gravis and start with the case. So the case is a 29-year-old woman who comes in with new onset of fatigue and weakness. The weakness she describes as intermittent. It kind of comes and goes, and it's located distally and proximally in all of her limbs. The symptoms have progressed over the course of a few weeks, and despite going to her local emergency room a few times, they have not been able to give her a diagnosis. She does describe some drooping of her left eyelid, or what we call ptosis. She's got double vision, or diplopia. She has some mild difficulty with her swallowing, dysphagia, and some shortness of breath, which of course you know is dyspnea. On her exam, she's a pleasant woman. She doesn't appear to be in any major distress. She's got normal speech. And on her exam, her cognition appears to be fine. She's alert and oriented. She's got normal language and memory, can do calculations. On her cranial nerves, she has normal movements of the eyes, but she says that she has double vision. And when you are examining her, you notice that her left eye has ptosis. And the ptosis kind of comes and goes depending on at what point you are in the exam. She has normal strength in her arms and legs and normal sensation, and her reflex as well. Toes are down going, and when you get her up to walk her, she has a normal narrow-based gait. So now we want to localize what's going on here. So what you've noticed is that this patient describes weakness. She's got weakness of one eyelid that on exam is coming, or on history is coming and going. She's got normal reflexes. So where could this possibly be? So it's very likely that this is outside of the central nervous system, given a lack of central nervous system signs. Although it's not clear yet if it's in the peripheral nervous system, where in the peripheral nervous system it could be. So let's learn a little bit more about this disease. So myasthenia gravis, the classic symptoms are ptosis, diplopia, abnormal speech, dysphagia, problems with chewing, and then many of these patients will have the shortness of breath also occurs and can become quite severe, and we'll talk about that in a few slides. So the fatigue and the weakness will typically occur to be fluctuating, but many patients will describe worsening over the course of the day. A good proportion of the patients will present with ptosis, and although our case has ipsilateral ptosis, frequently it is bilateral. And up to 90% of patients will describe these symptoms. A proportion of the patients will have diplopia or blurred vision as well. Extraocular movement involvement can occur in the course of the disease, even though our case did not have it. And then a smaller proportion will have limb weakness or palatal and pharyngeal problems. There are more than one type of myasthenia, and in some types of myasthenia, the bulbar symptoms are much more severe, whereas in others, the limb abnormalities are more severe. You'll want to make sure you know these classic symptoms of myasthenia for STEP. So this is a picture of myasthenia gravis, and what you can see in this picture on the right is bilateral ptosis. The incidence of this disease is uncommon. It occurs between 1 and 10 in a million patients, and it's more commonly seen in women. There are some peak age ranges for patients with this disease. There's a kind of a peak of onset in the 20s to 30s for both men and women, and then in the early 70s for men and women. The ratio of men to women who are affected with the disease varies in that in the younger ages it's more likely to be a woman compared to a man. Mortality is about 1.7 per million, and we'll talk about what leads to mortality. This is the most common neuromuscular junction disorder, so if you're going to learn one, this is it, and it's very likely, again, this is going to be tested on STEP. So let's remind ourselves of the neuromuscular junction. It's very likely at this point you've had a lecture from Dr. Hepner about the neuromuscular junction. The neuron has a relationship with the muscle in that there is a neuromuscular junction or synapse that sits between them. The presynaptic portion of the junction is at the end of the neuron, and the postsynaptic portion of the junction is on the myofibril fiber. What you can see in this picture is a closer-up view of what's happening, and really the main activity that's happening here is related to acetylcholine. So acetylcholine is made at the synaptic trough. It is taken up into synaptic vesicles, released into the cleft, and once released into the cleft, it can pretty much perform some of the actions needed in order to have normal nerve and muscle firing. So there are multiple disorders of neuromuscular transmission, and they can be broken down according to location at the neuromuscular junction where the abnormality is. I'm pointing out two of the major ones, myasthenia gravis, which this lecture is focused on, which is a postsynaptic problem, and Lambert-Eaton myasthenic syndrome, which is a presynaptic problem. Now you will also be hearing about botulism and I believe tic paralysis, but there's some other abnormalities that can cause presynaptic neuromuscular junction problems. The first are some abnormalities with magnesium. You can have a scorpion or black widow bite that will cause a presynaptic problem. Aminoglycosides, which are medications, can lead to presynaptic problems, and choline acetyltransferase deficiency, which is a rare disorder, will also result in a presynaptic abnormality in patients. Postsynaptic disorders, again, we could have drug-induced myasthenia, and I have a list of the drugs. There's a whole host of them that can do this later on. Congenital myasthenic syndrome, also I believe will be discussed by Maureen. You can have cobra bite and cause a postsynaptic problem, and again there are some other medications here that are both depolarizing and non-depolarizing agents. Synaptic problems are seen with congenital myasthenic syndrome, cholinesterase inhibitors, and with organophosphates. So there is a classification of myasthenia. The Myasthenia Gravis Foundation of America calls class 1 ocular myasthenia, and those are patients who present with predominantly ocular abnormalities. Class 2 are patients who have generalized mild myasthenia. Class 3 are more moderate. Class 4 severe, and Class 5 patients who are intubated. Myasthenia is known for worsening with a whole host of exacerbating factors. Patients who have high amounts of stress, who've just had recent surgery, who are infected and have a fever, patients who have just delivered babies or around their menstrual cycles, thyroid disease, and medications can all exacerbate symptoms of myasthenia. You may or may not be able to identify the exacerbating factor, but frequently patients will be able to tell you something that is associated with their symptom onset. This exacerbating factor list is important to remember when you're studying for STEP. Patients with myasthenia will have improvement in cooler temperatures and in drinking cool liquids or eating cool solids, and we can actually use this piece of information for diagnostic purposes. There are several associated conditions due to the autoimmune nature of the disease, including rheumatoid arthritis, lupus, Sjogren's, and a host of others. The pathophysiology of myasthenia is that this particular disease is autoimmune mediated. Now, when I went to medical school, and I hope I'm not aging myself too much here, we did not know that myasthenia was autoimmune mediated. We kind of thought it was just a neuromuscular transmission problem and that it occurred maybe because of genetic reasons or others, but we didn't understand that this was all related to antibodies. So we know it's autoimmune mediated because there are antibodies present in the neuromuscular junction, and IgG from myasthenia patients can cause symptoms in animal models. If you remove the circulating antibodies, you actually decrease the severity of disease. The antibodies reduce the number of functional acetylcholine receptors, and there's a host of mechanisms with which this occurs, also reviewed by Maureen. So myasthenia gravis antibodies are important diagnostically because we can test for them clinically. So most patients who come in with myasthenia will have acetylcholine receptor antibodies sent. And a good proportion of them, 80 to 85% of them, will return back positive. These receptor antibodies can be binding, blocking, or modulating. And most commonly, you're going to see binding receptor antibodies in patients who have generalized myasthenia, with still high but smaller proportion in patients who have ocular myasthenia. And these are most specific for the disease. Now, some anti-striated muscle antibody, and these patients will frequently have a thymoma, which we'll talk about in a later slide. This particular antibody is useful to test in patients who have been tested for acetylcholine receptor antibodies and are negative. This particular antibody can be nonspecific, and it is positive in other diseases, especially associated with cancers like lung cancer. So if you receive a positive test back, you will, of course, want to have the clinical phenotype in order to believe that it's associated. So myasthenia gravis is associated with problems with the thymus gland. And frequently you can have not only issues such as fatty replacement with the gland, but you can have atrophy of it as well. About 10% of myasthenia patients will have a thymoma, and 55% of patients with thymoma will have myasthenia gravis. So if you have higher titers of these acetylcholine receptor modulating antibodies, there's a much higher risk of thymoma. So thymic hyperplasia, when you look at it, the thymus is going to be present in about 70% of myasthenia gravis patients. Removal of the thymoma may improve myasthenia symptoms in 70% of patients. And this is a major point to remember. So long before we even understood that this was an autoimmune disease, we knew about the presence of thymomas, and the thymomas were removed, and patients improved. There was some suspicion that this meant that there was some immune system problem that was going on, but this, again, was prior to the discovery of the antibodies. So how do we work up a patient who has a neuromuscular disorder? So in a patient who comes in with myasthenia phenotype, the first thing we'll do is send off antibody testing. MuSK antibodies and PQ-type voltage-gated calcium channel antibodies can also cause a patient to present with a myasthenic appearing syndrome, although these are much less common. MuSK antibodies tend to occur in women and are of a much lower frequency, and the voltage-gated calcium channels antibodies are associated with cancers. The tensilon test is a test that we will do specifically for myasthenia. Nerve conduction studies and EMGs are common tests that we use in neuromuscular disease workup, but we may use a particular type of nerve conduction study with repetitive stimulation or do a particular type of EMG like a single fiber EMG when we're looking at certain neuromuscular patients. A CAT scan of the chest is frequently ordered to look for thymoma, and a malignancy workup should be considered for Lambert-Eaton myasthenic syndrome, which we'll come back to at the end of this lecture. Stool testing can also be done for infection. So for myasthenia gravis, the tensilon test was traditionally the best way to look for myasthenia. What this is it's an idursulfase injection, and this particular drug will inhibit acetylcholinesterase for about 5 to 10 minutes. So what will happen is that you'll administer the drug and the patient will improve, sometimes quite dramatically right in front of your eyes. If our case with the patient with the ptosis was given this particular test, you might find that her ptosis is completely resolved for some period of time after getting the injection. The issue with administering this in the office is that it does have some side effects. In some patients, it can trigger atrial fibrillation and bradycardia. So you want to make sure when you're giving this particular test, you have an EKG available and atropine as required, as needed. One issue with this particular test is that it has a 20 to 30% false negative rate, especially in ocular myasthenia. And that's why many neurologists now will just immediately go to receptor antibody testing, as it has a lot higher likelihood of being positive in the disease. Another test that we do, especially if you don't have access to some of these more sophisticated ones, is an ice pack test. So if you hold ice over the eye that has ptosis for 2 minutes, about 80% of myasthenia patients with ptosis will improve. And this capitalizes on that issue that myasthenia symptoms will improve with cool temperature. Now, I just want to make a couple comments about nerve conduction velocities and electromyography. This particular type of test is ordered and performed by neurologists. Some neurologists are specialists in neuromuscular disease, but if they're not specialized and see only neuromuscular disease, you can get certified to do these tests in the clinic. So you also see these in neurologists in private practice. This particular type of test is used for diagnosis of neuromuscular diseases and can be quite helpful to localize peripheral neuropathies, motor neuron disease, neuromuscular junction diseases, plexopathies, and radiculopathies. It's also very helpful in identifying both sensory and motor abnormalities in the peripheral nervous system, and can tell you if you're dealing with a demyelinating problem of the nerve or pure axonal loss. If you can differentiate between these two things, it may also help you with your differential diagnosis. This particular test, although there are standard ways of administering it, can be individualized. So if you have a patient who only has a problem in the right arm, you probably are not going to spend a lot of time focusing on the other limbs except as needed for comparison. So for myasthenia gravis, for electrodiagnostic testing, what you frequently will find is that the nerve conduction studies are normal. So because of this, we actually do a more specialized test called repetitive nerve stimulation. And what happens is that if you stimulate the nerves to a certain hertz, you can deplete acetylcholine enough that you can see abnormalities. So we will see what we call decrement. And decrement are more likely to be seen in weak and in proximal muscles. And I think I have a picture of this on the next slide. So this is seen and is abnormal quite frequently in generalized myasthenia, although it's much less common to see in ocular myasthenia. So again, in ocular myasthenia, we may have to do a different test for this. EMG can be normal. EMG is the portion of the test where we actually put a needle into the muscle and see how the muscle is behaving. Although EMG is frequently normal in myasthenia gravis because we're dealing with a neuromuscular junction problem, sometimes you can see abnormalities. So the test on this slide that is important, especially for ocular myasthenia, is single fiber EMG. And in single fiber EMG, you're actually performing EMG on one of the muscle fibers. And this is useful because the ocular muscles are smaller, and it may be what you need to find an abnormality. So here are some pictures of both repetitive nerve stimulation and of single fiber EMG. So on the top we see repetitive nerve stimulation, and on the left is a normal response. So as you continue to stimulate, you have a very nice, robust response from the nerve. However, on the right, what you can see as you continue to stimulate, you're essentially depleting that acetylcholine, and you get a decrement in the appearance of the response. In the bottom with the single fiber EMG, what you're going to see is again an abnormality in the response of the muscle, and instead of having this nice waveform, you can see in the lower right, you have kind of a smearing of the waveform, or what we call jitter. And this is an abnormality, especially that we use in ocular myasthenia for diagnosis. So I just want to comment on the safety factor, which is the ability of the neuromuscular transmission to remain effective under various physiological conditions and stresses. In a normal patient, we would not see a clinical effect with repetitive stimulation. You're going to have essentially a normal waveform when you do that test. However, in myasthenia gravis, you have this decreased safety factor. And as you do repetitive stimulation, you continue to deplete the acetylcholine. And at some point, it becomes insufficient to reach the threshold to fire. So the decrement that we see in repetitive nerve stimulation is translated clinically into fatigable weakness, which is what the patient will complain of in the clinic. So what do we do with our myasthenic patients? Well, a lot of our care surrounds the support of the patient. These patients can get into trouble because they develop bulbar or respiratory dysfunction. And some of the patients, if they have proximal or limb weakness, especially in the legs, will have difficulties with walking and will fall. Because respiratory function can be affected in this disorder, we will often send pulmonary function tests to get an idea of where the patient stands. Forced vital capacity and negative inspiratory force are the two tests that we look for abnormalities on in order to gauge some idea of how we should be treating them clinically. We also want to be aware and counsel our patients regarding those triggers that can acutely worsen symptoms. So for treatment of this disorder, and it's likely you'll hear more about this in your neuropharmacology lectures, the mainstay, the oldest way that we have of treating this disorder is by using acetylcholinesterase inhibitors, or pyridostigmine. Mestinon is the drug name for this. Now this is a symptomatic treatment. It doesn't actually impact the disease course, but it is a mainstay of treatment for myasthenia, and we are still using it today. This medication is likely to show up on your STEP exam. Now, because this is an immune-mediating disease and is related to antibodies to the receptor, immune suppressants are very important in treating this disease. Also, we will use immunomodulation and use either IVIG or plasma exchange to try to pull off those antibodies to improve the clinical signs of the patient. Thymectomy, as we mentioned before, can improve myasthenia symptoms, so these are going to be performed in a large majority of the patients who have them. So I want to have one slide here on myasthenic crisis. So any of you who will be rotating through the intensive care unit, especially the neuro ICU, may encounter one of these patients. It is estimated about 1 in 5 myasthenic patients will have a myasthenic crisis at some point in their illness. Patients who have prominent oropharyngeal or respiratory symptoms will need ICU monitoring. There are indications for intubation, especially if the FVC gets below 1 liter. We will also intubate patients who have an elevated PCO2 for obvious reasons. We want to make sure in patients with myasthenic crisis if there's an exacerbating factor that we treat it or remove it. And these patients are going to necessitate acute treatment, immunotherapy or immunomodulation with plasma exchange. And usually we'll need to do 4 to 6 exchanges to try to rapidly remove those antibodies to improve the patient and to get them extubated. So what is the prognosis of patients with myasthenia gravis? So in 2 of 3 patients with this disorder, the maximum severity is seen in the first couple of years. The active disease state with relapses and remissions may last for up to a decade. But subsequently, some patients will go into an inactive phase for about a decade. And finally, there can be a burned out state where you have less exacerbations. There are several drugs that we want to avoid in myasthenia. I've mentioned some of them already, but the list is very long. So if you have a patient with myasthenia gravis, you can either get help from your local neurologist or you have a list that you can refer to when you're giving them medications for other disorders. I just want to comment finally on Lambert-Eaton myasthenic syndrome, as this disease also shows up frequently on the STEP exam. This disease is much less common than myasthenia gravis, and in these patients they have autoantibodies to the presynaptic calcium channel, which also lowers acetylcholine release. These patients look a little different. They tend to have proximal muscle weakness, dry mouth, and impotence. They have a lot of autonomic dysfunction. And these patients actually improve with exercise or with muscle use. This particular disorder, unlike our classic myasthenia gravis, is much more associated with small cell lung cancer. So if you identify somebody with Lambert-Eaton, you immediately need to go order a chest CT or other workup for cancer. These patients do not have benefit with acetylcholine inhibitors. So here are a couple of references if you're interested in looking up more information about these disorders. And I will take any of your questions virtually. I'm at Deborah, DEBORAH _A_Hall @rush.edu.